And what we're going to do today actually is to have some best of San Antonio from surgery, radiation oncology, and then medical oncology. And of course, we want to answer your questions as you go along. So if you have questions about things we didn't talk about, do feel free to talk about them. So Rachel Yang is going to talk first about some of the updates in surgery. And again, if something isn't clear, you don't understand something, please do let us know as we go along with that Q&A box. So Rachel, you're on.
So today I'm going to be focusing on two very exciting studies that are helping us better understand how we do surgery on the lymph nodes with the diagnosis of breast cancer. When we talk about lymph node surgery, what we mean are the axillary lymph nodes, which is a fancy word for the lymph nodes in your armpit. So next slide. This first study looked at lymph node biopsy in older women. And the question that was posed is, should we be doing lymph node biopsy in older women over 70 years of age? They looked at almost 3,000 women, and the average age was 75. Most of these women had quite small tumors, so we're talking about 1 to 2 centimeters in size. And this study was performed by developing a mathematical model to look at the relationship between the biopsy of the lymph node and the effects on survival. Next slide. Here I'm going to review the major findings from this study. The first significant finding was that for women who were more than 74 years of age and had low risk and small tumors, almost all of these women did not die from breast cancer after 5 years. So this was an excellent survival, being more than 95%. And we found out that this was true for those who had cancer in their lymph nodes and also for those patients who did not have cancer in their lymph nodes. And even more interesting was that this was the case for women who had hormone therapy, some of those common medications being anastrozole and letrozole, but this was also true for women who didn't take hormone therapy. A second major finding of this study was that compared to women who did not have cancer in their lymph nodes, with women who did have cancer in their lymph nodes, if they did not take hormone therapy, they're slightly more likely to die from breast cancer after 5 years. Next slide.
Before I go on to the next slide, maybe you could say that again, just so that people understand it. So if...
Yeah, so I can try and make that a little more simple. The first point being that if you're over 74, so 75 and older, and you have small cancer and a low risk cancer, that you're very likely to do well after 5 years, not die from your breast cancer. And that's regardless of what is going on with cancer being present in your lymph nodes or not. And it's also regardless of what medication you take. So if you're 75 and older, you have a small, low risk cancer, you're going to do well. Number two being, if you're older woman over 70 years of age and you do have cancer in your lymph nodes, it seems to be a bit more important to take hormone therapy.
So that's really helpful. And I think that it's also helpful to take from this that that's not true for all 75 and older women. If you're well without comorbidities and you had a node positive cancer, you might not die in 5 years. And that is really important, but you could have recurrent cancer and still die sooner than you would have. So we do still really encourage hormone therapy in this setting.
And the major conclusions from this study was that it's reasonable and likely safe to avoid biopsying lymph nodes in women who are over 70 years of age if they're willing to take hormone therapy and if they have low risk cancers. Additionally, biopsy of lymph nodes can be avoided in women over 75, even if they're not willing to take hormone therapy, assuming that their cancers are very small and low grade.
Let me just ask Michael, your thoughts on this too, that is 5 years enough time to be following these patients for mortality, for death?
Yeah, so that's a great question. I think we always like to have longer follow-up, but it does show, at least for these women over the age of 75, that leading up into their early 80s, that it's highly likely that they'll do well. But you're right. I think in terms of the lymph node surgery, this really goes towards the concept that the societies for breast surgery and also within radiation oncology, that really this concept of choosing wisely, and that we should be able to give women the option, if they have low risk tumors and they're small, to potentially not do the lymph node surgery. And that may mean that they can have their lumpectomy surgery, removing the tumor, saving the breast without general anesthesia. So I think what's really important is that it means that we can at least offer that to women. It doesn't mean that we can't do the lymph node surgery, but at least we can offer them. But I think what's really important, as I think Dr. Rugo was stressing, is that even in these women that are over the age of 75, that we really think that the hormone therapy is a really important aspect of their treatment, especially if they're going to avoid the lymph node surgery. And I'm sure as Dr. Park in the radiation oncology division would agree, that if they're thinking about potentially not doing radiation, that the hormone therapy is a really important part for their treatment. But you're absolutely right, Dr. Rugo. I think there will be continued follow-up, but this is good data so far, so that we can think about potentially de-escalating some of the surgical aspects that we have been doing in the past.
It's really helpful. Rachel, you want to keep going?
Yeah, we'll move on to our next study. And this is a bit more of a complicated question about what we should do with surgery on the lymph nodes after you've had neoadjuvant chemotherapy. And that's the word for having chemotherapy before surgery. So the question of this study was in women who are known to have cancer in their lymph nodes. So women who've gotten a new diagnosis of breast cancer, and at that time they already are told they have cancer in their lymph nodes. If those women then have chemotherapy before surgery, what's to be done at the time of surgery with the lymph nodes? Next slide. This study looked at about 600 women who were found to have cancer in their breast and in their lymph nodes. These women all had chemotherapy before surgery, and all of these women did not have any lymph node swelling before they went to surgery after the chemotherapy. What happened in the study was that all patients who went to surgery on their breast, whether that be a lumpectomy or a mastectomy, partial or full complete removal of the breast, all of those women had a biopsy of the lymph nodes. And in women where there was cancer in the lymph nodes or only 1 or 2 lymph nodes removed, all of those women had to go for complete removal of the lymph nodes. So if there was still cancer present at surgery, then they went for surgery number 2 for the big removal of all lymph nodes in the armpit. Next slide. This study found that in women who did not have all their lymph nodes removed, so those women who just had the sampling of the lymph nodes, of all these 600 women, only one of them had a cancer come back at 5 years in the lymph nodes. And second, in women who had radiation after surgery, none of them had cancer return to the lymph nodes. So the major conclusion from this study is that in women who have cancer in their lymph nodes and in their breasts when they're diagnosed, then undergo chemotherapy before surgery, removal of all of the lymph nodes, that's something called an axillary dissection, can potentially be avoided or at least discussed about being avoided if they are found to have no cancer at the time of their lymph node biopsy and if several of their lymph nodes have been biopsied. And so what this tells us is that potentially we can do less surgery on the lymph nodes. And this is really the direction we're going with breast surgery, trying to understand how less is more, how we can get the information that we need to help understand treatment and prognosis, but not cause harm.
Yeah, I think that this is a really important to try and ratchet back some of the things that we've held true for a long time, because we end up with having people, if you have a big node dissection, you have a lot of nodes, and then you have to have radiation, your risk of lymphedema and nerve problems is really high. And it used to be, the thinking was that if you had positive nodes before you got neoadjuvant chemotherapy or chemo before surgery, that you then had to have a node dissection. And we did that for decades. I mean, and then the sentinel node biopsy came around. And then as we realized that patients did very well if they had complete shrinkage of their invasive cancer, there has been a tendency towards doing less node surgery. So this kind of data really supports the idea that if you had a great response, you could have much less node surgery. Michael, do you want to comment on that?
You said it perfectly. That's exactly correct. I mean, I think we really have been trying to do less, especially in the armpit or axillary lymph node surgery, because of the side effects associated with it. And for a long time, just like in all aspects of cancer therapy, we did things because we thought we had to do as much as possible because it would be the best outcome. But more and more clinical trials and studies have shown that really doing less in the right situation is a much better option. And especially, as Dr. Park can comment on now or later as well, in the radiation department, the radiation is doing such a fantastic job for the potential microscopic residual cancer cells that may or may not be there. So there have been a number of clinical studies showing that radiation does an extremely good job as long as we choose the right patients. And I think what's important that Dr. Rugo knows is that our group, that's what we do. We have a discussion about each patient to kind of determine what the benefit is of these different treatments, and being able to do less for specific patients has been a great thing for them.
Yeah, I will just add a few comments. I think Dr. Alvarado is exactly right. In the adjuvant setting, in the past few years, we've had a couple of trials showing that in patients with limited disease in their lymph nodes, that radiation can be very effectively used in lieu of axillary dissection. And what they found was it's better tolerated and has much less, avoids lymphedema risk. And so that's been a real sort of progress forward in really understanding how limited surgery and radiation can work together in selected cases. So I think this abstract is also really important because it's in the neoadjuvant setting when patients have lymph node involvement in the beginning, and we're still sort of evolving and understanding what is the sort of optimal surgery in limited nodal disease after neoadjuvant, and the role of radiation in that setting as well.
And Kathy, did you have any comments about the first presentation?
Yeah, I'm going to be actually talking about this group of patients who are a little bit older, who might have, lower risk cancers, and what the options are for radiation therapy. And I think there are similar themes going on in that we're trying to de-escalate where possible and really personalize. So really understanding individual biology better, using more and more tools to help assess risk are really helping us to move forward in that direction. So I have the abstract I'll be updating about is on that topic.
And then Michelle, just a brief comment about that first abstract where we, if you had an older woman who, how do you sort of interpret 5-year survival data?
I think that, I'm sorry, I'm just starting my video because I didn't want to be distracting during other people's presentations. I think it is important. And I think there was actually a question in the chat box
there is.
that maybe, maybe worthwhile, to sort of address here, to say someone was asking about, how long are you predicting these women will have a long enriched life, to say 95. I think that really is, where, we are lacking, because 75 is, 65, we, especially, here in the Bay Area, we have patients that are extremely healthy, take great care of themselves. I mean, I have, 80, 82, 85-year-olds who are, hiking Machu Picchu. I mean, it's just crazy, what these women are capable of. And so I think that, we have to consider that, the patient population, how we can extrapolate it to our patient population who may live to 95. And I'm actually, I just want to throw out here, and I definitely don't want to be, I think this is great data. We want to do less is more. But one of the things that worries me, is that this sort of the reducing the amount of axillary surgery, and then Kathy's going to talk about deciding who we can, eliminate radiation from. It becomes very confusing, I think, for the patient when they hear, they're referred to medical oncology to talk about hormone therapy. They're referred to radiation oncology to talk about radiation, and they've already bypassed, an axillary node dissection or a completion node dissection. And then they come to us and we're saying, well, you have to understand that in that trial, everybody who got, didn't get radiation, we're assuming was compliant with their hormone therapy, or vice versa. And so then, there's this idea that, how do we help a patient decide what is going to be better tolerated? Is it better for them to go ahead and do the radiation and not do the hormone therapy? But the data suggests that the hormone therapy is really important, particularly for those patients. And speaking of the first presentation that Rachel made, that the hormone therapy is very important for patients with positive nodes. And then for those patients that have, positive nodes that don't have, opt to have a full node dissection, that the radiation is important. So we can't de-escalate too much, especially for these women who are expected to have another 10 to 15 years to live. So that's my takeaway.
Yes, and I would agree with you. I mean, I think that we do have a quite a clinic population of patients in their 70s and 80s, and I think it's really no fun to have metastatic disease. So I would say that we do believe that most of these patients should receive hormone therapy, even though we can avoid radiation, and we're going to hear more about that now, and about how we treat patients now and what we're thinking about in terms of managing radiation in lower risk patients who are older. So let's go to that now.
Great. Well, Dr. Rugo's pulling up the slides. I'm going to talk about a study that was first reported on with 5-year updates, and at San Antonio, there was a 10-year update. And in the evolution of breast cancer radiotherapy, which for breast conservation really started in the 70s. So we've been doing this for about 50 years. And it's been really interesting and exciting to see how breast radiotherapy has evolved. It's still considered the standard of care in most women, but as we've moved into the mammographic screening era and we've been able to detect earlier stage disease, disease that is more indolent, and in populations where we feel like the natural progression is going to be extremely slow, we've asked ourselves the question, when is it too much to utilize radiation really in everybody? So really talking about that topic. The next slide. So the background of this is that we know in general that when we look at many studies all lumped together, so this is from a meta-analysis where we put tens of thousands of women who've had breast conserving surgery and radiation and look at outcomes over many trials. And it really tells us the really important trends. And what we know to be true over time is that radiation therapy is very effective in reducing the risk of local recurrence, in fact, by 2/3 on average. But the absolute benefit for any individual depends on what their risk is. So if you're an individual who has only a 5 to 10% risk of having a local recurrence, then your benefit from radiotherapy is going to be relatively small. Whereas if you're someone who has a 40% risk, then your benefit's going to be much bigger. And the other thing that we've found is that with every local recurrence that we can prevent, that maybe we're also impacting survival. We don't tend to see this effect in women who are very early stage, but certainly with more advanced stage disease and with chemotherapy, we can see a survival benefit from radiation therapy. But it's certainly true that not all patients have local recurrence, and there's a spectrum of risk. So there's definitely opportunity to personalize, as I mentioned, and many studies have really been focused on identifying individuals and predictive factors that help us understand risk and therefore select patients more appropriately. So the next slide. So the questions that really are addressed, that we're addressing with this particular abstract, and then I am going to present a few more that weren't presented, but just to give some background and context, is, does every patient who has lumpectomy for early invasive breast cancer need radiation therapy? We know, I've already talked about local recurrence being something we want to avoid, but that it's actually pretty low risk in some populations. And is there a group in whom we then feel that the risk is sufficiently low that we can treat safely without radiation therapy? So the name of this study is PRIME, which stands for, I want to make sure I get it right, the post-operative radiotherapy in minimum risk elderly patients. There's another study that was also done among patients who are 70 and older, but I also take what Dr. Melisko said to heart, is that biologic age is not necessarily, or your chronologic age is not necessarily your physiologic age. And we're seeing many, many women live very robust and full lives well into their 80s and 90s. And so I think when I see the word elderly mixed with someone who's 65, I sort of kind of catch my breath and think, wow, is that, I don't think we consider that elderly anymore. But anyway, this was designed many years ago. So this trial looked at patients who were very selected. They were 65 and older, early stage invasive breast cancer. They had to have pathologic assessment of their nodes. They're all node negative, and they had pretty small tumors. So they were mostly 1 to 2 centimeters, even though they allowed up to 3. And they had to have good risk biology by pathologic factors. So these are things that we ask our pathologists to comment on under what they see under the microscope. So it only allowed one sort of feature that sort of looked a little bit more aggressive. And the patients all had lumpectomies and were eligible for hormone therapy. And then they were randomized to receive radiation therapy by standard radiation to the whole breast. And then these are the 10-year results that are being reported. So the main aim was to assess the impact of omitting radiation therapy in these older patients who had early stage disease who received endocrine therapy. And the primary endpoint of the study was local recurrence. Next. So this is a busy table, but I'll just highlight a couple of things. One, you can see the mean age of the patients was about 70 with a standard deviation of 5. So this is 65 to 70-year-olds, mostly 70-year-olds. The tumor sizes were all pretty small. As I mentioned, they were all up to just 2 centimeters, very few that were larger. And even though they allowed, grade 3, which is a more aggressive, it reflects a more aggressive biology, there are very few patients that were actually grade 3 in this trial. And there are very few that had what we call lymphovascular invasion, another pathologic sort of feature of aggressive disease. So overall, this was a very selected cohort of patients who had very favorable disease and who received endocrine therapy. So next slide.
And Kathy, just somebody had asked in the box, these women must all have hormone receptor positive disease.
That's right. They had to have hormone receptor positive disease. Great question. Thank you.
These kinds of omitting treatment is generally not done for people who have, for example, triple negative or more aggressive HER2 positive cancers, right?
That's right. Absolutely. So we'll see that in other trials that were designed in a similar fashion. So these are the main results of the study. On the left, you see that patients who had no radiation, the local recurrence was 9.8, or about 10% at 10 years. And then 1% for patients who received radiation. Oopsie.
Yes,
and that is about the proportional reduction that we expect from radiation. It's actually a little better. So patients who had radiation, very, very low risk of local recurrence. And then patients who didn't have radiation had a 10% local recurrence risk. But on the right side, you see that there is no difference in survival. And the other detailed data I didn't put in here is they didn't have difference in breast cancer survival, overall survival, or any difference in distant metastasis. So that's an important point, that the local therapy did not make a difference in that regard. Okay, next slide. This is metastasis-free survival. So I wanted to make that point, that there was no difference in the development of metastasis. So this was not a cohort of patients who would have a survival benefit from radiation. As I mentioned in the beginning, that there are some patients who can potentially benefit in survival. And this is not that kind of cohort.
The other thing that's really striking about this is if you look at the 10-year survival rate, the numbers are so high.
Yes, exactly. So there are very few mortalities from any causes in this whole. So this is a healthy cohort. And I'm going to mention another study where the cohort wasn't as healthy, and it was, but a very similar design, similarly designed study with similar conclusions. So this was reassuring that it was a healthy cohort. They didn't have a lot of competing risk factors for death from other causes, and that their breast cancer truly was effectively treated by hormone therapy, and that many women did not need or did not get treated with radiation therapy.
And I think everybody on the call knows that RT is radiation therapy, but just in case not. And then the other thing just to note is they're looking at the number of patients at risk. In other words, how many patients from how they started are still being evaluated at each time point. So you can see that when you get past 5 years, the numbers go down quite a bit, but you still have, you can tell here that the median follow-up here is about 5 years, but there are patients who are out to 10 years.
Right. Thank you for making that point. Very important. And the 5-year results were actually about half the local recurrence rates as the 10-year results. So at 5 years, it was about 5% local recurrence for no radiation and less than 1% or 0.5% for patients who had radiation. And it basically just very slowly accumulated over the next 5 years, so that by 10 years, it was 10% and 1%. So this was, I thought, a really interesting slide that they included in the presentation. And that is results by estrogen receptor status, or the amount of estrogen receptor that was expressed. So ER means estrogen receptor. What they didn't say is what was the cutoff. So what did they mean by high and what did they mean by low? But what this shows you is that in patients who had low estrogen receptor and they were getting hormone therapy, they actually had a higher level of local recurrence versus those who had high estrogen receptor who had a lower level of local recurrence. And I interpret this to mean that the hormone therapy was just more effective in the patients who had high levels of estrogen receptor expression. And that seems to make sense. And that this is perhaps yet another tool for us to help refine our decision-making around, who is most appropriate for just hormone therapy, or who actually would benefit from having the addition of radiation. And to me, this indicated that, well, we should be extra careful in patients who have low estrogen receptor expression, that they may actually have added benefit from radiotherapy.
These patients who have low ER may have a little less sensitivity to hormone therapy and act a little bit more like our patients who have ER negative tumors, particularly in older women, where the biology is unusual to see those very low ER. Somebody has asked, Kathy, if the ER level was measured by the all-red score. I don't think we know that here. It would be unusual. I think this is probably percentage of ER.
Yeah, and this was it was sort of a pre-recorded session, so there wasn't really too much in the way of answering questions, but that certainly would have been a main question that I would have asked this group. I'm sure it'll come out in their publication.
Yeah. The other question that somebody asked was how long they were on aromatase inhibitors, and we would expect hormone therapy to have been the classic 5 years, right?
Right, it was 5 years. I think it was tamoxifen.
Everybody, because this is an older study, people receive tamoxifen in general.
Right.
And then the last question was, I don't know if if the 10-year follow-up included quality of life metrics.
In this particular study, well, I know there were some quality of life metrics done in similar studies, so I'm not sure that it was done in this particular study, but I will get to that concept at the end. That's a good question. So the conclusions are sort of what we summarized, that there was a 10% local recurrence at 10 years for selected patients who had hormone receptor positive cancers, who received endocrine therapy and no radiation. And it was about 1% in the patients who had radiation. But there's less than 6.4% of deaths that were due to breast cancer. And a subset of patients with low ER expression had higher local recurrences with no radiation. So in this next part of my talk, I just took the liberty of putting a slide in of a couple of studies that had a similar design and gave us a little bit more perspective about how we're choosing patients. And then I'll end with a couple studies that are into just their design as we're moving forward and what we're trying to answer. So the CLGB 9344 study and the Canadian trial, which included patients who are 50 years and older, were very similar in design to the PRIME2 study. They selected patients who are early stage, had invasive breast cancer, were clinically node negative, hormone receptor positive. They all received endocrine therapy and were randomized to receive radiation or no radiation. So let's look at just the graph from the CLGB study. And this was even a study that preceded the PRIME2 study. These patients were 70 years and older. They were clinical stage 1, very similar to the PRIME2 study, as I said. And you can see on the top graph, after many years of follow-up, more than 10 years, that the patients who had tamoxifen and radiation therapy had very low local recurrence. It was 2%. Versus patients who had no radiotherapy, it was 10%. So you can see remarkably that these numbers are very consistent between the PRIME2 study and this study. And that there was no difference in breast cancer specific mortality, distant metastasis, and overall mortality. They actually also reported on eventual mastectomy rates, which were also the same. One of the caveats of this study was that the morbidity, comorbidities were high in this population of patients. So there were, high levels of cardiovascular disease and other comorbidities. And so one wondered whether the competing risks were actually playing a bigger role here than we could detect from the therapies. But I think we're learning more from PRIME2 that it's not really the case for this cohort that's highly selected. Now, the next study is the Canadian
One thing very quick is that most of these patients probably would receive aromatase inhibitors now rather than tamoxifen,
Right.
in particular older patients. And so we might actually expect even a further improvement in both local regional recurrence-free survival and distant recurrence-free survival.
Absolutely, that's a great point. So we know from the ATEC trial and others that the AIs are more effective in this population than tamoxifen. So the Canadian study is worth mentioning because it was designed at the same time as the CLGB study, but it included women who are younger. They're 50 years old and older and had the same sort of study design you can see here. But the local recurrence at 8 years was much higher in the patients who received no radiation. And so it really showed that we can't just lower the age or select those patients based on staging or the criteria we're using, because when we include those younger patients, we're seeing much too high of a local recurrence risk that people were comfortable with. And so this study was important in that regard, but they did a very interesting follow-on study to this one, which looked at a subset of patients who had better or more favorable disease. So the next slide shows that study. And oh, wait a minute, before I go to the next slide, sorry, what I want to say is those studies that we have just looked at were designed in an era before we were really using the molecular subtypes in selecting patients. And so for you're probably all familiar, but for patients who are have strong estrogen receptor, progesterone receptor expression, we designate them as sort of a luminal A or a subtype that's very favorable. And those are the patients that are largely included in these studies. But we know now that there's HER2 and triple negative phenotypes or subtypes that are more aggressive, and patients can have higher local recurrence rates despite radiation therapy for those subtypes. And then, of course, there's Oncotype Dx and Mammaprint and PAM50. These are all molecular prediction assays, which have been largely developed to help us understand chemotherapy effect. But future studies are really looking to see if these can also help us predict local recurrence effect and therefore help us further personalize local therapy. So the next study is really based on that Canadian study. And that's why I thought it'd be worth mentioning it here. And what they did is they took a subset of those patients, 500 of them, and they were able to look at their estrogen receptor, progesterone receptor subtype, and they estimated those patients who had luminal A type or favorable biology disease versus other subtypes. So there were some HER2 positives and some other triple negatives in the cohort, which maybe were not detected when the study was first designed. But basically what they found was that if you look at just the luminal A patients, that they had a very low risk of local recurrence at 10 years. It was 3%. And so that was, another confirmation that if we can choose the biology, a very favorable biology, that is certainly a good direction to be going in. Okay, so the next slide. So this just shows you a snapshot of two slides or two studies that are have been designed and are accruing. And this just really helps us to further make progress in understanding patients who may not need radiotherapy. So the first study, called the Luminous Study, will have the same sort of early stage patients, still highly selected, and will randomize luminal A. And IDEA is another study. They're going to look at Oncotype as a potential predictor for local recurrence. So these are the types of studies that are now moving forward in younger cohorts of patients. So you can see here, Lumina is for age 55 and older, and the IDEA trial from ages 50 to 69. So in my last couple slides, I just want to go back to the quality of life issue. And this is really when patients have very low risk. I think Dr. Melisko mentioned this. We say, well, go and talk to your medical oncologist, talk to your radiation oncologist, and it just seems like it's so complicated. There's so many choices to make. And I think there are more trade-offs to make when you have lower risk disease, because you have to commit to the same types of therapy that you have to commit to for if you have higher risk disease. So I think it's true for patients with low risk disease that I see them trying to really figure out, well, what is the right choice for me? And so we often go over, the discussion is just to say, well, what are the side effects? What can you expect? How well tolerated is the treatment? And breast radiation therapy is pretty well tolerated. It's a standard 3 weeks of whole breast radiotherapy is what's typically given. But that being said, a lot of these patients are also candidates for what we call accelerated or partial breast radiation therapy, which can give you more intensive doses in a shorter period of time. So this is sort of another whole hour of talking about partial breast and other kinds of fractionation that have been developed in this space. And the next slide just points out that there are side effects associated with both radiation and AIs, so anastrozole. And so that's what makes this a space where we really need to do more quality of life studies and have patient preferences well known, so that we can make decisions together in this domain. So that's all I have to say.
Well, I think that's incredibly helpful. And I think there's a few things we could talk about here. One of the questions that, it was really nice that you ended with the quality of life part. And I think that, one of the questions that someone has asked in the box here is, what's the maximum years that I can take Arimidex or anastrozole? Is it 10 years or over 10 years, et cetera? And obviously, we're always balancing side effects here. I don't know, Michelle, what are you sort of thinking about in terms of who you recommend 5 years versus 10 years of an aromatase inhibitor?
Yeah, that's a great question. It's interesting, that there are patients that are counting the days until they finish their 5 years. And, many patients who can't even imagine getting to 5 years. And then there are patients that get to 10 years and are like, I want to stay on this because it makes me feel safe. So there's this whole spectrum of patients. But I really, think we have to tailor it to a patient's, risk. And obviously patients that, we thought had biologically high risk disease, many positive nodes. I recommend more therapy, longer therapy. And I do use the breast cancer index. I know that, we don't have time to talk about this tonight, but, there has been more and more data, supporting the use of the BCI to support the use or not, use of extended adjuvant hormonal therapy, trying to select the patients that are going to benefit. But none of it really tells us what to do for patients who've completed, 10 years. Is there any safety data for an aromatase inhibitor beyond 10 years? And I sort of extrapolate that in the MA17 trial, patients took 5 years of tamoxifen. There's a subset who took AIs out to 10 years. So I will go out to 15 years with an AI for patients who are tolerating extremely well, who don't have, major issues with bone density or cholesterol or other, complicated health issues. A bigger question is who needs to do that. So I think the BCI is our best tool right now. That's in my opinion. Is I do use that assay. And for those in the audience who aren't familiar with that, it is an assay, a prognostic and predictive assay, similar, but not the same as Oncotype or MammaPrint, where they have validated data to say what is a patient's prognosis in terms of risk of distant recurrence between years 5 and 10 for hormone receptor positive breast cancer. They previously had data for node negative patients, and now they have more compelling and data for node positive, 1 to 3 positive nodes. And they have validation also in patients taking tamoxifen to continue beyond 5 years. So I do use it to help me define that. I think the tough thing though is there's prognostic information and then there's predictive information. And the test also tells us for the, which patients based on a couple of markers, patients that are likely to benefit from the extended adjuvant hormonal therapy. And I think my biggest challenge is what do I do with a patient who has, a high risk of recurrence between years 5 and 10 and are predicted to have a low benefit from extended adjuvant therapy. And those are, of course, that's the sort of, there's 4 different options you can get as a result of that test, and that's the worst. And I've had a few lately, and it's a tough discussion. So I'm curious to hear what you do in for those patients, who find out that, perhaps their risk of recurrence, late recurrence is higher than we'd hoped for, yet we don't think that adjuvant endocrine therapy is going to help them that much.
It's interesting because I generally would only send the HI or this biotheranostics test. Although I think they're just bought by another company, I assume it will still be called biotheranostics test. But I only use it for patients where I have equipoise about duration of endocrine therapy, and of course where patients are tolerating treatment well enough to stay on. So in a patient who has high risk disease, nodes positive, et cetera, where we're going to extend endocrine therapy in general if we can, I wouldn't send the test. But I think for earlier, stage 1, or maybe you have a tumor that's 2.5 centimeters and node negative, then it's more helpful. So then these results aren't quite as difficult to manage. So I think that, these studies that have been done have been really great with the HI test, but I think that we need a little bit more. And we're really looking forward to results from a trial from one of our large national cooperative groups where they looked at actually 5 versus 10 years, essentially. The trial, a group called the NSABP, where they collect tumor samples and have a lot of current day data. And they have made some negotiations with many of these companies that make these kinds of tests. And you go back to the original tumor the patient had that's in the lab and test that and try and figure out benefits. So I keep looking every year for that data. I'm hoping in the next 2 years we see it, but I think that will help us. The other thing I think that comes up is, so, again, the discussion to answer the question of the patient, what the maximum years I can take anastrozole or Arimidex is really based on individual risk and a discussion with your oncologist about other biologic factors in your tumor and how we are tolerating the treatment. But for both, I think, surgery and radiation oncology, one of the things I've been seeing more recently is that patients have gone to surgery and felt that having more surgery might be better, that they would have a mastectomy. We've heard this for a long time because then you wouldn't have to have radiation and, you don't have to do imaging anymore and you don't have to worry. And in the most extreme cases, patients who don't have a genetic risk will have bilateral mastectomies. And the downside is sometimes when we discover positive nodes, the patient would have to have post-mastectomy radiation, which is unfortunate. How do you manage this question for patients? And sort of as a corollary of that, and we'll ask about, maybe I'll ask Rachel and Laura about neoadjuvant therapy after that. So Michael, do you want to start with that?
Yeah, sure. Those are always, that conversation comes up a lot about, well, I can avoid the radiation if I do a mastectomy. And I think one of the issues is that, unfortunately, a lot of women have a different concept of what the radiation actually is. They've heard these really terrible stories about people that have had radiation for throat cancer or radiation for colon cancer that have caused a lot of problems. And it is true that those cancers and the radiation can have a lot of issues for people, and it's really, really difficult. What they don't realize is that, as Dr. Park mentioned, for breast cancer, radiation is extremely well tolerated with very, very, very few side effects after a lumpectomy, without pain or problems. So I think one of the things is that we try to educate them about, what the radiation is to try to get past some of those fears. And actually, Dr. Park and her team are always open to having us send the patients to see them even before they make their final decision. Because just as Dr. Rugo said, it's not uncommon that someone decides, well, I'll just do a mastectomy, then I don't have to do the radiation. And unfortunately, there's something that's found at the final pathology that says, well, actually, we really recommend the radiation in this case as well. Now, after a mastectomy, the radiation can have some significant side effects to the reconstruction aspect. So there are some downsides in those cases. But it really is, I think in our group, just like with the medical oncology group and the radiation oncology group, we really try to give the patients all the information we can to help them make the best decision for them on a single patient personal decision. And it is true that some women decide that they don't want to do any more imaging. They're worried about getting multiple biopsies in the future. And so they do opt for something like bilateral mastectomies. And I think at the end of the day, just like within medical oncology and radiation oncology, we're with them 100% if that's what their final decision. But up front, we want to make sure that they have all the best information to make those decisions.
Kathy, do you want to add anything there?
Yeah, I think Michael stated that also well. Shows we've worked for a long time together, but radiation is so well tolerated and the techniques are only getting better. Everything about left-sided breast cancer, sometimes women have more, anxiety about that. And it's also, it's important, and it's important for us to think about cardiac risk as well. But we have deep inspiration breath hold type techniques and our treatment planning techniques that really help minimize the risk. It's very, very low, really not anything we can measure. So I'd say we're always, improving on that. And the only thing I'll add to what Michael said is I do see patients propel themselves sometimes towards a mastectomy and without having the sort of ability to pause and talk to everybody and realize that you don't have to make an emergency decision. you can take some time and sort of think about it, because it is a life-changing decision. So we really try to support the decision. So as Michael said, we're always happy to talk to people, even if they're really like about to have a mastectomy, just to make sure they understand everything about radiation, so they can make the best decisions for themselves.
That's really great. And I think one of the things that comes up for us before we start on the med-onc part is the value of neoadjuvant therapy versus doing surgery first. And we do tend to see a lot of patients who have their surgery scheduled in 2 days, and we're thinking, wait, we want to try and treat. So Laura, do you want to briefly mention your sort of thinking on that?
Sure. So neoadjuvant therapy, as you know, it means that we give a medical therapy before surgery. And typically, many years ago, we would always take patients to surgery first and then follow up with chemo or endocrine therapy afterwards. But there's more and more data now that there are many situations in breast cancer where we actually want to give therapy before surgery. So give the chemotherapy or the HER2 targeted therapy. And there's two real reasons for this. I think the first one is it allows us to see if patients are responding to therapy, because every week we can examine their breast mass, and with imaging also see if the therapy we're giving them is actually shrinking the mass. And that gives us an opportunity, if it's not shrinking the mass, to then change our plan and maybe do something more aggressive, or if it's actually shrinking really fast, to de-escalate and maybe give them less aggressive therapy. And then the second reason is that also, if we can shrink the mass down up front, it gives us the opportunity to potentially do a smaller surgery down the line. So I think really for those two reasons, there are certain cases in breast cancer where we, especially triple negative cancers and HER2 positive cancers, that we do like to do these therapies up front.
And Rachel, do you want to comment at all about sort of the surgery approach to neoadjuvant versus adjuvant therapy?
Yeah, I think for us, the benefits are what Laura said, but also surgical in nature, in that you can come in with a large breast tumor that might not be amenable to having breast conservation, meaning a lumpectomy followed by radiation. And neoadjuvant in so many cases can shrink that tumor so that we can do very limited breast surgery and either preserve the nipple and do a mastectomy with nipple preservation, or really just do a lumpectomy with no mastectomy at all. Furthermore, as discussed in my previous slide review, is that we might be able to avoid unnecessary surgery to the armpit as well and to the lymph nodes. We think of it as quite a benefit to do neoadjuvant surgery in the neoadjuvant before surgery.
One of the things that sometimes comes up, Kathy, is that there can be worries about that maybe you didn't check the nodes, and so you don't really know how much radiation to do. Some of the data that you all presented, I think, suggests that that's not really the case, and that there really isn't a downside for anybody I can ever think of starting with chemotherapy first, if chemotherapy is indicated.
Yeah, I agree with that. I think the more and more we are understanding about the role of sentinel node biopsy after neoadjuvant, and where we have to actually implement axillary surgery, just as the abstract that Rachel presented, the more we're going to understand the role for more expanded radiation. So I think at this point the morbidity from treating those fields is fairly low, and especially if there isn't extensive surgery. So I hope we more and more move to that point where we really understand where we can avoid full axillary dissection, post neoadjuvant chemotherapy. That's still the main question for most of us.
I think one of the things we also teach people about is that your risk is from the cancer you have and not from the cancer you don't know you're going to get someday. And that's really important too, that we want to base our treatments on what you have now versus, I think, sometimes fear of what might happen in the future. There are some questions in chat, I think, for Michael and for Kathy. And then we're going to go on. I'll let you answer them in chat. And we'll start with Laura. Let's see. Why is it? Sorry, I got some other thing here. I don't know why, but I'm getting there. Okay, now we are going to move into the world of medical oncology and still stay with early stage cancer here. And Laura, you're up. Are you there, Laura?
Sorry, I'm muted. There we go. My name is Lori Huffert, and I'm one of the fellows that works with Dr. Melisko and Dr. Rugo on the medical oncology side. And I chose a couple of abstracts from the medical oncology side to share with you today. The first one is from a trial called RxPonder, a clinical trial for positive node endocrine responsive breast cancer. As you can see, I underline the relevant letters, and the key here is making the title add up to RxPonder. So it's a funny thing in medicine. So the background is the Oncotype Dx Score, which most of you have probably heard about already, but just as a reminder, we have several tests like the Oncotype and the MammaPrint, which use the molecular characteristic of the tumor to help characterize which tumors tend to be more aggressive and have higher scores versus those that have lower scores. So the Oncotype Dx Score is used to help identify patients with HER2 positive hormone receptor positive, HER2 negative, lymph node negative breast cancer who can safely forego chemotherapy. So if you click Taylor RX trial, they score patients and divide them based on age. And if the risk score is in the range of, if the patients are younger and the risk score is in that intermediate range of 16 to 25, they may derive chemotherapy benefit, although it kind of depends in that range. But if patients are older, if the score is less than 25, there's evidence that they will not derive chemotherapy benefit. And the unclear in this trial, as I said, this is a trial where the lymph nodes were negative in all of these patients. And so can we extrapolate this data into lymph node positive patients? So the clinical question here is, can we use this test in lymph node positive patients and better understand, is endocrine therapy enough? Or will some of these patients also benefit from chemotherapy? So this trial was designed, like I said, it's ER positive, HER2 negative patients that have 1 to 3 positive lymph nodes. They were basically randomized. So we got their Oncotype Dx score up front. And if it was greater than 25, they weren't eligible for this study. They would go on to get chemotherapy. So that's the bottom part. But if they had a score of 0 to 25, they were eligible to be randomized. And so they randomized 5,000 patients. And arm 1 was chemotherapy followed by endocrine therapy. And arm 2 was the control. It was basically what we're doing now, is that endocrine therapy alone. And first I'll show you the data for post-menopausal women. And so for post-menopausal women, the chemotherapy and endocrine therapy is the red line up top, and then the endocrine therapy is the blue line. And you can see basically there's not a significant difference between these two lines. They're almost, on top of each other, meaning that there was no difference in invasive disease-free survival or the amount of time until you have disease between whether you got chemotherapy or not. And similarly, when they looked at overall survival at a 10-year period, there was no difference in overall survival between these two groups. And so really they concluded here that in post-menopausal women, if they had lymph nodes that were positive 1 to 3 and a score less than 25, they didn't benefit from chemotherapy, and they did just as well with endocrine therapy alone. And interestingly, in the premenopausal group, we did see that there was a little bit, you can see these lines separate. The patients who got the chemotherapy and endocrine therapy, which is described as the CET at top, had a slightly better 5-year interval disease-free survival at 94.2%, versus those patients that got endocrine therapy alone, or the blue bottom line, had a 5-year interval disease-free survival of only 89%. So those lines were slightly separated, suggesting that the younger patients, premenopausal patients who got chemo, did a little bit better. And similarly on overall survival, that was also statistically significant difference. And so those patients that got chemotherapy at 5 years did slightly better than those who got endocrine therapy alone. A caveat being, of course, as we mentioned with the prior studies that Rachel's and others presented, we're only looking at 5-year overall survival data here. And recurrence can occur later than that. So ideally, we'll have even more survival benefit 10 and 15 years out down the line. But I think this was a pretty interesting piece of information for us because previously, these patients, we would think, is endocrine therapy enough? And this is suggesting maybe we should think about chemotherapy, but I'll get to a couple caveats in a minute. Next slide. So to summarize just one more time, for postmenopausal women, those lines were on top of each other. There was no difference. And so really the study emphasized that they did not benefit from chemotherapy. But for premenopausal women, this study did suggest there could be a benefit from chemotherapy when added to endocrine therapy in these specific patients. And a couple caveats. So one big question is, when the younger women got chemotherapy, chemotherapy typically shuts down the ovaries, at least temporarily, and sometimes permanently in some of those patients. So a big question really is the chemotherapy effect not actually due to the benefit of the chemotherapy itself, but really we're seeing that the chemotherapy is shutting down the ovaries, and that's why we're seeing this benefit. And so I think that was a big question that many medical oncologists had, and something that we'll need to tease out in the data going forward. And another thing I think I just want to leave you with is, we're still trying to figure out here, some patients need more therapy, some patients need less therapy. And so trying to figure out how we can use some of these tests like the Oncotype Dx and to better help predict, whether a patient might need more therapy to prevent recurrence versus whether we can get away with less and still, have a favorable outcome. So I think this is just one of those studies getting at trying to tease that question out a little bit more.
Michelle, do you want to comment a little bit on what you're taking from TAILORx now into the clinic?
Yeah, sure. I mean, unfortunate for, genomic health, now Exact Sciences, I think that this tells us that, honestly, I don't find that the Oncotype is a useful test for patients that are less than 50 who have positive nodes. There was no way to discriminate the benefit of chemotherapy in this patient population. So, it's interesting. I kind of go back to when the TAILORx data was presented, and, all of the press releases were, about, oh, we can spare women chemotherapy. And, we've been doing that since 2002 when we first started using, the Oncotype assay. And in fact, what we find is that for younger women, there's actually suggestion that, younger women or premenopausal women or age of, less than 50, that we really need to, offer more therapy, whether it is chemotherapy or whether it is, whether it's ovarian suppression and, more aggressive endocrine therapy. But the reality is that, my takeaway is that I don't think that the Oncotype, based on this data, I won't use it in premenopausal or women under the age of 50. As far as what it tells me, it's really reassuring that, the Oncotype is valuable and can help us discriminate who needs chemotherapy in women, postmenopausal women. So that, as far as the discussion about whether, there are women that are younger that might benefit from OS plus AI or OS plus tamoxifen versus chemo, I don't know how we can make that assessment. I have to say, this drives me to offer more chemo to younger women.
Yeah, I mean, it's an interesting question. I think there was a lot of noise on Twitter after this was presented, and certainly one of my colleagues at Dana-Farber, our colleague, Hal Burstein, said, well, the answer to, what TAILORx showed us was chemo doesn't benefit patients with an Oncotype score under 25, period, a 25 and under. And what he really strongly believes is that this small benefit in chemotherapy seen in the premenopausal women, and remember, the percentage here are not absolute percentages, but relative percentages. So the absolute percentages were very small. Still, we like incremental benefits in breast cancer outcome. But I think that a lot of people have thought, and Hal Burstein certainly the most vocal, that this represented ovarian suppression. In other words, preventing the ovaries from making estrogen from chemotherapy effect. And of course, some of these women received ovarian suppression injections, but many received tamoxifen. And this was the first presentation of TAILORx. So we really need that additional data to try and answer, I think, some of the questions that Michelle is bringing up now, which is that, can we use this in premenopausal women to try and better understand benefit? And I would say in my mind that the answer isn't there yet, that I think that for smaller disease with a low score and one positive node, I still feel comfortable with the endocrine therapy approach. But when you get to multiple positive nodes, I think you're in a much more difficult situation with younger women. So I don't know. I understand what you're saying, Michelle, and I still maybe am on the fence there.
Yeah. Well, I guess when you say small benefit, I mean, if we look at the, if we look at the TAILOR-X study and you look at the absolute benefit of chemo in women under the age of 50 for women who have scores between 21 and 25, it's not minimal, it's substantial in terms of the benefit of chemotherapy. And so we don't have those numbers in responder, but I feel like if you believe in the test and you say, well, even in node negative patients, we see, a 4, 5, 6% difference in distant disease-free survival at, 8 or 9 years in patients that got chemo versus those who didn't, in women under the age of 50. My sense is it's got to be that much or better. Although I agree with you that the grade 3 node negative patient may be very different than the grade 1 node positive patient. That's where the devil is in the details. So that's all. That's where the devil is in the details.
You can see the absolute differences here. As Michelle points out, 5% is a lot, but this really what we care most about in giving chemotherapy is distant recurrence risk, and it wasn't separated out yet in this first presentation of our exponder. And in fact, what happened was the deadline for abstracts for San Antonio was many, many months before this data came up. And then there was a late breaker deadline and that passed. And then early November, before the meeting in December, they had this data. And San Antonio is nimble enough that they're able to look at something that is practice changing and accept it. But this is really just hot off the press data. So we do need to see a little bit more information to try and understand what is, how to really interpret this data in premenopausal women with low-grade cancers in one positive node. It's not clear that those patients benefit from chemotherapy. So it's an interesting question. Also, one question to actually ask all of you guys again is that, you can see a patient who's say 68 and has a 0.9 centimeter tumor, estrogen receptor positive, but the recurrence score is 29. How do you deal with that? You're sort of trying to balance the size of the tumor against a question about benefit of chemotherapy. Michelle, what do you do with that situation?
So you said how big again?
0.9 centimeters.
Yeah, I mean, that's always challenging because, those patients, those patients weren't randomized. I mean, in any of these studies, TAILOR-X responder, they weren't randomized, they were assigned chemo. So we have to say, we don't know that small subset of patients that had clinically low risk cancers that just were assigned chemo because that's what their Oncotype score was. I still feel like these tests, you either believe in biology or you don't. And if you are, I sort of take it that if you're going to order the test, you have to, follow the results. And so with a score of 29, I'd say, well, the consensus of all the experts that designed these trials said that someone with a score of 29 should get chemo, and I would offer chemo.
Yeah, I would too. What is other people? Any other comments that people want to make about that? I think that the benefit is modest, but it's very hard. There's a new, just to mention before everybody speaks, because I'm talking instead of asking, but is that there is a new calculator on the Oncotype website. So Exact Sciences now it's called. And you can actually put in age and grade and the planned hormone therapy and the size of the tumor. And it will give you a sort of relative risk of recurrence based on a lot of accumulated data from other studies, so that you can estimate the potential benefit from chemotherapy. So for example, even if your score was 29 and you had a tiny cancer and you were older, you might say that the amount of benefit that's estimated is too small to make chemotherapy worthwhile. So I think that is not for node positive diseases yet, just node negative. It's called RS-CLIN, and it's easily accessible on the website, so that if you do have score and you want to try and estimate that, that is something that might be useful. You have to remember that it's only an estimation. But other comments about responder or use of these genomic tests? And be sure to send your questions in if you have any questions about this. Before we move on and talk about a oral taxane in the metastatic setting, which I think is very interesting, there's been a question here for a little while that we get, I think, every single day, probably
10 times a day.
10 times a day, right? Did you say 10? Yeah, okay.
10 times a day.
And that's hearing about the COVID vaccine and what to do. And I think the biggest questions are, should I get the vaccine if I have cancer? Does it matter if I'm on active treatment or I have already finished my treatment? What about if I'm taking chemotherapy or a CDK4/6 inhibitor like Ibrance, Verzenio, or Kisqali? So I'd love to hear, I guess, Michelle, do you want to first comment on that? What do you tell people?
Yeah, I think we're all, we've all discussed this, and we're recommending the vaccine for anybody at any time, whenever you can get it. And, there's been discussion about patients, the question here was about patients on AI. I think that's completely fine. There's no issue. I mean, aromatase inhibitors are not immunosuppressive. They're not affecting your blood counts, your ability to respond to a vaccine. Something like Verzenio or Ibrance, these drugs can be myelosuppressive. You can see transient drops in the neutrophil count, but I don't think we know exactly if they have any immunosuppressive effects where you wouldn't respond to a vaccine. I think even in the face of patients that are getting immunotherapies or who are on, even intravenous chemotherapy, I think we all feel that the benefit of getting the vaccine is greater than the potential for harm. And then another question, just as an add-on that I've gotten probably 5 times in the last week, is whether patients that have some type of allergy, whether it be an allergy to Taxol or an allergy to contrast or some other allergy, whether they should take the vaccine, whether they should be monitored more carefully. And I thought, we don't know anything about this. I mean, lots of people have different kinds of allergies. I mean, one of our very close colleagues is, deadly allergic to bee stings and peanuts and tomatoes and everything. And, I think she got the vaccine just fine. So I think that, the incredible push is to give everybody the vaccine as soon as they can get it.
And then Michael, so in terms of, people getting the vaccine, do you tell anybody about a specific arm they should get it in, or do you have concerns about pre-surgery vaccine?
Yeah, we haven't really. Although I will say I did get mine and it hurt really bad. So I guess I might even tell them to get it in the same arm that we operate, so that if they have any pain, I can blame it on the vaccine instead of my surgical technique. But no, I think we've been telling people that if they're going to get it, to have it at least be 10 days before their surgery. I think only because from what I'm thinking is that if they had symptoms from it, they didn't want it to be confused with actually being sick and then having the case canceled or something like that. So, but otherwise, not really.
And how about you, Kathy? Is there a concern about getting the injection in an arm that's already had a node dissection and radiation, for example?
No, anecdotally, with my colleagues across the country, there have been just some discussion that you can get, some juicy looking nodes after the vaccine. And so it can, complicate an imaging study just depending on the timing of it. So if you're going to be going in for a routine mammogram or something like that, maybe, or you have, something that you're screening in particular to avoid that side, maybe. But this is all just very early and as we go, trying to, react to things that we're seeing. But I think we don't have anything very strict. I think I agree with, others that if you can get the vaccine, there's no contraindication if you're having radiation.
Even if you're doing radiation.
Right.
Yeah, I mean, it's interesting. So somebody commented on what I was going to say, but there have been documented cases of lymph nodes showing up on PET scan on the XL of the injected arm. And what was really funny was that I had two patients, both of whom were physicians, who had their scans, and they showed new lymph nodes that had been there, and they clearly weren't having any change in the cancer. One is without cancer at all, and one is actually doing incredibly well with responding to treatment. And it turned out, I talked to both patients had just gotten their COVID vaccine in that arm. So indeed, we do have to be cautious, evaluating patients who've just had their vaccine. And we've talked about that a lot in the neoadjuvant setting, that we prefer for patients to get their vaccine in the alternate arm than the side of their cancer, to try and avoid confusing things and any other issues with the lymph nodes that might be there. So we have a few more minutes, and I was thinking, maybe Lori, you could just briefly talk about what tezactaxel is, and unless there are any other questions, I don't see them online about COVID and the vaccine. I mean, we're hoping that our cancer patients who are under the age of 65 come up in the queue for a vaccine in the next few weeks. So we're really looking forward to vaccinating more patients soon.
Sure. Do you want me to jump in, Hope, again, or?
Yes. Mm-hmm.
Perfect. So I can briefly talk about Contessa, which is a phase 3 study of tezactaxel plus capecitabine, which is also called Xeloda, in hormone receptor positive HER2 negative breast cancer. And I think I wanted to share this abstract because tezactaxel is a pretty interesting drug that we might see more of in the future. So it's an orally administered taxane chemotherapy drug. So it's the same type of drug or the class of drug like paclitaxel or docetaxel, but it's given orally through the mouth. And one of the advantages of this is that it has a longer half-life than either of those other two. And it's also just easier to take things at home, especially COVID era, not having to come to the infusion center is nice. And so this study was interesting because it looked at, can we take this newer drug, this oral taxane drug, and combine it with Xeloda? And is that a better, more efficacious combination when they're combined? So I can just briefly go through this trial. So basically they randomized patients with hormone receptor positive, HER2 negative metastatic breast cancer who could have had 0 to 1 prior lines of therapy and could have had a prior taxane in the neoadjuvant or adjuvant, or they had to have a prior taxane in the neoadjuvant or adjuvant setting. And basically they were randomized to receive the combination of tezactaxel, this oral taxane, with capecitabine or capecitabine alone. And here the pink line in all of these bars is the combination of the tezactaxel plus capecitabine. And the top graph shows progression-free survival, or what is the period after starting the drug until you progress. And you can see that the pink line is higher, a little bit better than capecitabine. And that if you look at the median month table at right, the median progression-free survival for the combination was 9.8 months versus 6.9 months. So, almost over 2.5 months better with the combination. And similarly, they saw an overall response rate was better and disease control rate was better. One question here is, what we really care about is the survival better? And the data wasn't mature at the time of the study, so we just don't have that data yet. We're hoping in the next year or two, we'll be eagerly looking for that data. Next slide, please. And I think a big question here was, what are the side effects? Is great, better, but can patients tolerate this? And interestingly, the combination had a lot more hematologic side effects, meaning affecting the blood counts. And so there was more neutropenia, or one of the neutrophil lines were down, neutrophil cells were down in the combination arm compared to the capecitabine arm. And there was also more diarrhea. You can see 12.5% of patients had grade 3 diarrhea in the combination arm, and 8.9% in the capecitabine alone arm. And so I think important for us as providers, if we do move in this direction, to counsel patients about the risk of having the low blood counts and the diarrhea, and figuring out how we can best manage that. There was, of note too, it's not on this table, but there was grade 2 alopecia, so some hair loss in the combination group compared to much less with the capecitabine alone, but only 8.0%, so not only less than 1/10 of patients.
So do we want to just briefly talk about that, because it's now 7:30, that this is an oral taxane? I think the disappointing thing for some people was that the tezactaxel, an oral taxane, was only given with capecitabine or Xeloda. So it was an all oral regimen, but it was more toxic than if you just gave the tezactaxel alone. So I think there's great interest now in seeing how this works on its own. If you could take a pill for a taxane every 3 weeks and have a little chance of losing your hair and much less neuropathy than we would expect, that would be really great. So that's the sort of exciting part about this, I think, for us now, and we hope to see regulatory approval for it. But I think that they studied the tezactaxel and capecitabine based on approval for a combination of Taxotere or docetaxel and capecitabine from many, many years ago. So that's why they chose this. I think many of us would have preferred to study tezactaxel as a single arm, like a single agent as one of the arms, but that wasn't really feasible. And this is a company that has no approved drug. So a lot of times the most expeditious approach drives the study design. To answer the attendee who asked if it's common to give concurrent combination chemotherapy, we don't do it a lot in hormone receptor positive disease.
So Hope, would you, when this, because you're an expert in this drug, I mean, so if and when this gets approval, which presumably it will you give this as a single agent instead of standard IV Taxol? I think the answer is yes, but don't want to speak for you.
Yeah, I would. And I think that, you could, for example, if the approval is in combination, you could do a short induction with the combination, then drop the Xeloda. We didn't do that in the study, but I did have one patient who was completely intolerant of Xeloda capecitabine, probably due to metabolic issues. And we did have to drop it. And she had liver metastases, which completely resolved, and she stayed on it for a long, long time. In fact, even though she's on a new therapy now, due to more cancer in bone, the liver metastases haven't come back. So I think that, the drug is going to be active. And I actually was just talking to them this morning, encouraging them to look at, a single arm study with tezactaxel as a single agent. But again, they had a small study initially. Presumably that's what you would do also, Michelle?
I think so, yeah.
There's another oral taxane we don't have time to talk about today, but we certainly can continue our discussion at the next forum. We're really excited to, I think, see all of these information. As we end, I'd just love to get a couple of sentences from each of our wonderful panelists about what they're most excited about seeing in the next, say, year. Maybe we'll start the way we began. Michael, do you want to start?
Yeah, sure. I think, in the surgical realm, we're always interested in trying to do less, if at all possible, especially as Dr. Yang had mentioned with regards to the axillary surgery. And as Dr. Park knows, there are clinical trials going on, even for women that have positive lymph nodes after chemotherapy, that it's highly likely that not doing a lot of axillary or armpit surgery would be beneficial, and that the radiation would do a very, very good job. So we're looking forward to that kind of data. And then I think also, as Dr. Melisko touched on, and also Dr. Huffert, that utilizing these genomic assays for not just, and also Dr. Park mentioned it earlier as well, but not just for the chemotherapy benefit, but really starting to look at the local surgeries or the local treatments like surgery and radiation, and utilizing these genomic assays to help direct local therapies as well. So I think those are the kind of areas that we're really excited about. And then obviously the fabulous job that you do in the neoadjuvant setting to make us look good for surgery when, all the margins are negative because they've had a complete pathologic response or something like that. So anything that's better for you all, it makes us look much, much better as well. So thank you.
And Kathy?
Yeah, I think, surgeons and we have a common goal in local therapy. So when we can do less, it's great. And we can work together to optimize the treatments. So in terms of the trials, Michael mentioned a couple that are accruing, and we hope we get some data on those soon that really addresses what to do with patients who have residual disease in the armpit after neoadjuvant, and how we treat them with either surgery or with radiation. Just the other area that I didn't get to talk about, but I'm really excited about, is the treatment of limited metastasis with radiation therapy, because we don't employ sort of wide field palliative radiation the same way. We now have very laser focused ablative therapy. And we've been working with our colleagues to kind of, in certain cases where we're treating patients with limited metastatic disease, And it's allowed us opportunities to, to have long-term progression-free survival. There are some new trials that came out in the past few years in that area. So I'm very excited about that concept in general.
Yeah, I think this idea of oligometastatic disease and how we treat cancers is an interest for all of us, and we're really hopeful to see more. Michelle?
I mean, there's so much, to talk about in terms of both, decision making in early stage disease. We hopefully the next forum will talk about perhaps like the Monarchy trial and other trials that have looked at the CDK4/6 inhibitors in early stage breast cancer to try to reduce risk of recurrence. I'm also really excited. I mean, although we didn't present much of it and it wasn't presented at San Antonio, about looking at patients with high risk but early stage disease, trying to figure out, what are things like circulating tumor cells and cell-free DNA, and what are the roles of, monitoring those things, and what can we do beyond, once we've completed neoadjuvant therapy or adjuvant therapy to try to reduce risk of recurrence. I think that the stuff that Joe Sperano has been working on with, looking at cell-free DNA and circulating tumor cells and adding different therapies post neoadjuvant and adjuvant is great. And then in the metastatic setting, of course, my passion is in brain mets, and the fact that we have some HER2 targeted therapies that are effective in brain mets. I think our biggest challenge is we still don't have a lot of great options for patients with triple negative disease with brain mets, and not a lot for leptomeningeal disease. But I, did see a few things that look promising. So at next forum, we'll talk about it.
Laura?
Yeah, I think building on what Dr. Melisko said, thinking about all the combinations that we can look forward to testing with some of these new oral agents. And then Dr. Rugo's kind of been a pioneer in this area, but whether immunotherapy can be useful, especially for our patients with triple negative disease, and how can we combine immunotherapy, which basically harnessing the body's immune system to fight cancer along with some of our chemotherapy agents. So I think a lot of work to be done in terms of trying to figure out which regimens can, do the best for our patients.
I think from my point of view, I think there are exciting things. Somebody asked about how they could learn about new endocrine therapies, and these are being studied, so they're not available in the clinic yet, but they are available in clinical trials. We're looking at drugs like Faslodex, which is an injection that recently all my patients have been complaining about in terms of pain with injection, but there are new oral agents of that class that are being tested. We're looking at some new targeted agents in combination with hormone therapy. All of these studies are being done in the metastatic setting, but our colleague Joe Chen is doing just starting up a multi-center hormone therapy trial before surgery, so neoadjuvant hormone therapy for special kinds of cancers that respond to hormone therapy where you don't want to give chemo. So I think that, we're going to be giving the oral drugs like Faslodex in that trial, and also we're going to be giving other targeted agents along with those oral drugs that are called oral SERDs. So that sort of tells you where, something about where you would learn about them is looking for clinical trials and understanding more about those agents. And the other things that somebody asked about, talking about triple negative disease, we didn't get to this, but we'll spend more time on triple negative disease, I promise, on our next forum. And we'll talk more about immunotherapy. I think that there will be actually an FDA hearing and a public discussion on February 9th about using immunotherapy as neoadjuvant treatment for triple negative breast cancer. So I think, you can actually listen into that if you're interested. If you just search ODAC, ODAC, which is the Oncology Drug Advisory Council, and you could search Merck and FDA because that's the drug that's being discussed. So that's actually really, it will be interesting. And we'll talk a lot more about some really cool new drugs that are being available for triple negative disease. And then the ER positive with brain metastases, there's actually also, Michelle's really been, leading this effort at UCSF, and there's also a lot of interest in this area as well, although I have to say that generally those cancers tend to respond a little bit better to our therapies. So I really appreciate everybody's taking time out to volunteer to do this, and all of you who are listening in, and Melody for her incredible volunteer work making this forum happen. It's just really a great event, and we couldn't do it without all of our incredible colleagues who are willing to give up their time, and for all of you. So I thank you very much, and we look forward to seeing you in the April forum. Send us your thoughts, your comments, and suggestions. Take care. Have a great evening. Stay well and be safe.
Thank you all. Take care.
Bye-bye.
Night. Bye-bye.
Thank you.